but it's moved very rapidly, so it already has a past. We'll then focus on where are we at currently with this technology and the conditions that it is able to analyze at this time, and then end with the future of where are we headed with NIPT. What can you expect if we're standing here a year from now having this conversation? So if we think first about the past, researchers spent many, many years developing a non-invasive prenatal test, and in doing so they had four main objectives to fulfill. So as a reminder here, obviously non-invasive, as it implies, means that they were looking to develop a test that did not require a puncture of the uterus and have with it obviously the associated risk of miscarriage. So that's pretty self-explanatory. But some other perhaps less obvious goals include that the testing needs to be something that can be made very easily available to women across the world. So if we think back to the initial analyte that researchers were focusing on, fetal cells, it turns out that that was a very difficult technique that wasn't really going to be easily expandable globally. We would of course want the test to have a high sensitivity or a high detection rate. So even if it was easy to do but it wasn't very accurate, then there's not much point in administering that test. And then lastly, and perhaps most on par with the reduction of risk to the pregnancy, is a decrease in the false positives. So you heard from Dr. Yu this evening the experience with first trimester screening in Singapore, and what she showed was that out of several thousand patients who had undergone first trimester combined screening, a number of those were screen positive. And in the screen positive cohort, the traditional next step is to offer CVS or amniocentesis for confirmatory testing. What her data also showed was that only 6, I believe, out of over 75 patients who underwent invasive testing had a true positive result. So that's less than a 10% true positive rate, meaning over 90% of those patients underwent an amniocentesis needlessly. So again, one of the main goals with NIPT has always been, can this test be very sensitive, have a high detection rate, but also very specific, meaning a very low false positive rate, so that we don't have that same number of women undergoing needless procedures. I mentioned briefly, again in thinking about the past, that research did focus for quite a while on fetal cells as the approach for NIPT. Not only did it not work because it wasn't scalable globally, but it also didn't work because there are very few fetal cells in the maternal circulation, making it just very hard to even isolate those cells to begin with. Lastly, fetal cells didn't work because it was realized that they can persist in future pregnancies. So if a woman came to you with her second pregnancy and wanted NIPT using fetal cells, you would run the risk that you actually were testing a fetal cell from the prior pregnancy rather than the current pregnancy. So those were a lot of the struggles early on with developing a non-invasive prenatal test. What really made this possible was the discovery of cell-free fetal DNA by Dr. Dennis Lowe in 1997. And once it was realized that circulating cell-free fetal DNA exists in a pregnant woman's blood, researchers at Stanford quickly developed methods to test that DNA and make it into a non-invasive approach for aneuploidy analysis. So we talked a little bit about why fetal cells didn't work. Let's flip that then and think through, why does cell-free fetal DNA actually work as an analyte for NIPT? First of all, we talk a lot about cell-free fetal DNA, but it is actually a bit of a misnomer to call it fetal in origin. A lot of studies have recently been showing that we think that the origin of this so-called fetal DNA is actually from the cytotrophoblast from the placenta. So that's important to keep in mind as a clinician when you're counseling patients about cell-free DNA testing because it becomes more similar to a CBS versus an amniocentesis in terms of the material being analyzed. So the way that cell-free DNA originates is simply through programmed cell death. All of our cells are constantly turning over, and as they do, the DNA gets released into our circulation. Everybody has cell-free DNA, not only pregnant women. But when women are pregnant, they have not only their own cell-free DNA, but also cell-free DNA from that of the fetus or the placenta, more accurately. So those fragments are released into the bloodstream, and ever so kindly of Mother Nature, it turns out that they are fragmented in such a way that it makes it very easy to perform massively parallel sequencing. There's not a lot of work on the front end that needs to be performed with that sample. As I mentioned, maternal blood contains not only the mother's own cell-free DNA, but that of the fetus as well. And as compared to fetal cells, where there was perhaps 1 per million or 1 per billion in maternal circulation, you end up seeing a significant amount of fetal cell-free DNA, actually typically much more than is even needed to accurately identify aneuploidy. Cell-free fetal DNA is present very early on in pregnancy, so that women can have this type of testing and get information very early in their pregnancy. And the final point here, again in contrast to fetal cells, is that the cell-free fetal DNA clears very rapidly in the postpartum phase. So again, if we think about the fact that it's thought to be coming from cells in the placenta, as soon as the placenta is delivered, that cell-free DNA clears very quickly, such that this testing is an option for patients not only in their first pregnancy, but in any subsequent pregnancy. So that's the past in terms of what were the goals of developing a non-invasive prenatal test and what were the methods attempted. Using cell-free DNA, there are now really 2 main approaches, and both of these approaches that have been developed use massively parallel sequencing or next-generation sequencing, as you've heard described from previous speakers as well. So next-generation sequencing is really changing reproductive medicine in terms of tests in general, and includes non-invasive approaches now. So the first approach here is a next-generation sequencing which covers the entire genome. So it's called genome-wide sequencing. And what you see here is simply as it describes, the sequencing of the fragmented DNA in the maternal plasma is across the entire genome. So you're not looking for just sequences on 13 or 18 or 21, but rather sequencing any and all fragments found in the maternal plasma. And one of the reasons that this approach tends to be beneficial is that you don't need to design an assay where in your laboratory you're isolating or you're targeting certain regions. What studies have shown is that there tends to be biases that can occur with the targeted approaches and high assay failure rates as a result of that. So this is a very simple, easy, straightforward workflow, which then leads to most results being reportable at the end of the day. Another main benefit of the genome-wide sequencing approach is that you've got all of the information from that pregnancy across the genome. And although most laboratories are not currently reporting on other conditions, it's very easy to do so because you already have all of the raw sequence data. You simply need to work on the bioinformatics, the interpretation side of things, and obviously consider clinical implications and ethics as well. So the alternative approach that has been developed, and to be fair, does work as well and has some benefits, is a targeted approach. And there are 2 targeted approaches. One involves SNPs, one does not involve SNPs. Bottom line, both are targeted approaches, meaning as you see here, you're only focused on sequencing regions of interest, so chromosomes that you're currently reporting on. In theory and early on, it was felt that targeted sequencing was a useful approach from the standpoint of a cost-benefit scenario. You're not using as many reagents potentially. You can put more patient samples on a sequencer at one time. However, with the cost of sequencing dropping very rapidly, that's already becoming a non-issue. And unfortunately, what you're finding with the targeted approach is that you're not easily able to expand your test menu. You're not able to add additional conditions rapidly because you don't have that sequencing data already there in your sequencer. But again, both approaches are working, and what you'll see as of 2011 and moving forward are just hundreds, literally, of publications now coming out talking about non-invasive prenatal testing. And a lot of those first publications focused on clinical validation studies, so large-scale clinical trials showing that once we realized cell-free DNA is a good analyte and we developed the technology of how to do the sequencing and determine the aneuploidy risk, we needed to show that it worked, right? And in general, so this is specifically from Obstetrics and Gynecology in May of 2012. In general, these numbers are similar that you see across the board for all tests currently available. The important factors here would be if we look at the sensitivity or thinking about detection rate, they're very high, not 100%. Nobody's saying that this is an amniocentesis replacement or a CVS replacement, but a really great screening test. These are higher sensitivities than you see with any current screening test available. Additionally, keep in mind we talked about the importance of a low false positive rate. So if we look here at the specificity for the common autosomal aneuploidies, we see false positive rates well under 1/2 of 1%. That's a 10-fold reduction in false positives as compared to traditional screening methods. That then brings us to the present. So validation studies have been published, people are believing that this technology works, and patients are asking for it. Currently, there are 6 main laboratories across the world that are offering some version of a non-invasive prenatal test. And just to share with you, we talked through the whole genome sequencing approach versus the targeted sequencing approach. The vast majority of the NIPT laboratories are in fact using a whole genome approach. There's one laboratory in the United States using a targeted SNP-based approach, that's Natera, and there's one laboratory using a targeted non-SNP approach, that's Ariosa. But again, majority using whole genome. In terms of what's available from Illumina's non-invasive prenatal test, it's called the Verified Prenatal Test. And the current chromosomes that are analyzed would be your common autosomal aneuploidies, trisomies 21, 13, 18. Sex chromosome testing became available over a year ago now, and that really was designed to focus on sex chromosome aneuploidies, monosomiacs or Turner syndrome, which has a high miscarriage rate, Klinefelter syndrome, and the like. I will point out here, because I've learned this evening that PGS is not an option, perhaps due to sex selection concerns. When a sex chromosome aneuploidy is not identified, the Verified test, as well as the other NIPTs offering sex, will report XX or XY. So something to think about as you begin to bring NIPT into Singapore and how to work around some of those ethically debatable issues. What you see here is that it is an optional add-on to the current Verify assay. So it is something that clinicians could simply not make available to their patients or have discussions with their patients about benefits and limitations. This testing requires just 1 tube of blood, so you're not sucking the mom dry, which happens a lot during pregnancy. It's validated in the high-risk patient population, so a lot of those early clinical validation studies that came out over the past few years really focused on using this technology in the setting of a patient who is of advanced maternal age, so she's obviously at increased risk for these conditions. Situations where there's an ultrasound finding that's suggestive of aneuploidy, Any prior pregnancy that had aneuploidy increases the risk in subsequent pregnancies, etc. However, what we've been seeing in 2014 now are publications coming out looking at the performance of these assays in any pregnant woman, not restricting just to high-risk patients. The Verify assay is available for singleton pregnancies, as are all NIPTs. However, not every NIPT is currently able to run testing in twin pregnancies. Verify is. And last, you see here in terms of patient eligibility, egg donors accepted. So there's one method that I mentioned that uses a SNP-based targeted approach. And because of that SNP analysis, they do require a biological relationship between the pregnant woman and the fetus. Therefore, egg donor pregnancies are not possible to be tested. Consanguineous couples would not be eligible for that testing, nor would pregnancies conceived using a surrogate. The turnaround time for any NIPT seems to be 1 to 1.5 weeks. It's a pretty quick turnaround, which is nice. And then the test failure rate that you see here, that's become kind of a hot topic in NIPT right now. Again, having a lot to do with the different methodology that's being used. If you remember nothing else from this presentation tonight, please remember that NIPT is not synonymous with high test failure rates. It doesn't have to be that way. Lastly, at Illumina, formerly Prenatal, we do have a staff of genetic counselors whose sole role is to interact with healthcare providers using this technology to make sure that patients are getting accurate and up-to-date information both on the pre- and post-test side. I know genetic counseling is an issue here in Singapore. It actually is an issue in the States as well, and we have over 3,000 counselors in the States, and it's still not enough. So I know Asia Genomics, we're working with them, and they're working very hard to make sure that they're able to offer NIPT in Singapore in a responsible manner, including some form of genetic counseling. So where are we at currently in terms of professional medical societies' opinions or position statements on this new technology? Shocking to most, the American Congress of Obstetrics and Gynecology actually came out with a committee opinion in record time, and that really had a lot to do with the significant patient demand for this testing. And what you see is, in addition to ACOG, ACMG, the National Society of Genetic Counselors, and the International Society for Prenatal Diagnosis have come out with very similar statements. So what I've highlighted for you here are the key points from the ACOG and Society for Maternal Fetal Medicine Joint Committee opinion, which states that cell-free fetal DNA testing appears to be the most effective screening test for aneuploidy. You saw the sensitivity and specificity, hard to argue with that. For high-risk women though, so right now this technology really has been focusing on high-risk pregnant women. It's likely that we'll see similar statements coming out about all pregnant women in the near future as more and more studies are published showing no difference in test performance. The results should be an informed patient choice after pre-test counseling. So this is not a test that a woman comes into your office and says, I'm pregnant, and you draw her blood for. Rather, a discussion around the risks, the benefits, the limitations of this testing would be critical before a woman decides whether or not to proceed. And then any patient who does have an abnormal result following NIPT should be referred for genetic counseling. If there are not genetic counselors, really just hoping that clinicians take on the responsibility of explaining what these results do and do not mean to the patient, including stressing the importance of confirmatory testing, as this is still just a screening test. There are very few false positives, but they do definitely exist. And so worst case scenario would be a situation where a patient elects to terminate a pregnancy based off of an NIPT result without having confirmed that with amniocentesis. So there are really two ways that NIPT can be implemented in practice currently. Again, focusing more on those high-risk patients, but moving very quickly into all pregnant women. As you saw from ACOG, it actually seems to be the most effective screen, and they said it could be used as a primary test. So forget about the first trimester screen, the screens that are less accurate. You could simply start with NIPT if you so chose. And in that scenario, you're simply offering NIPT. If a patient accepts, she gets her results in about a week or so. If those results are negative, low risk, no aneuploidy detected, you're simply going to continue pregnancy management as you would for any other patient who is low risk or screen negative for aneuploidy. However, keeping in mind here, if the result does come back abnormal, genetic counseling is recommended, as is confirmatory testing. Pretty simple and straightforward, right? A slightly more complicated approach, but still a very useful one in clinical practice, is using NIPT as a secondary screen. So perhaps it's more cost effective right now to begin offering first trimester screening, and for those patients who are screen positive, rather than having all 77 of them go right to amniocentesis, maybe you offer them NIPT and begin to determine which of those screen positive patients are likely to be true positives and really should go on to amniocentesis versus which ones were likely to be false positives, which are going to be the majority and probably don't need to go on to amniocentesis. So using it as an intermediary step here, or secondary screen between your traditional screen and your invasive testing. I talked about the plethora of publications out now on NIPT, mostly clinical validation studies in 2011 and 2012. What you're beginning to see now are reports on actual test performance from the laboratory perspective. So now that this testing has been offered clinically or commercially for just over 2 years, are we in fact seeing the detection rates that we expected, the low false positives? Is the turnaround time as good as it was on the research side of things? And how many of those tests are failing? And so at Prenatal, we analyzed our first several thousand samples that came into our laboratory commercially and published in Prenatal Diagnosis last June, showing that the test accuracy in our commercial laboratory does perform as well, if not even a bit better, than what was predicted based on the validation studies early on. We do see false positives and want to be very transparent about that, but again, just at a significantly reduced rate as compared to traditional screening. And you will have occasional cases of false negatives as well. Again, this is not a diagnostic test. We were very pleased with turnaround time and test failure rates and have seen further improvements beyond that. There have also started to be many publications coming out from different clinics. What has their own experience been using a non-invasive prenatal test, and specifically what has happened to their rate of amniocentesis procedures. So if you think back to the two different ways that you can implement NIPT, the end goal is to have as few women as necessary undergoing invasive testing. And we feel that we are achieving that with non-invasive prenatal testing based on several studies, one of which you see here, 40% reduction in amnio procedures, 50% reduction in amnio procedures, and then a collaborative study recently published in the American Journal of Obstetrics and Gynecology looking at 6 different centers across the U.S. found every center had a decrease in procedure rates anywhere from 24 over 50%. And I expect that you will see more of this as we move forward. In terms of the present, to finish up, we're kind of on the line here between present and future. The New England Journal of Medicine in February published a study on the Verify test looking at NIPT as a direct comparison to your traditional screening, whether that was a first trimester screen, a quad screen, an integrated screen. and aneuploidy screen was eligible to participate. And what this showed, perhaps not surprisingly, was a tenfold reduction in the false positive rate for Down syndrome when comparing the standard or traditional screen to NIPT. So questions right now are coming up from clinicians. Is this test going to perform as well in any pregnant woman, not just high risk? And we feel that we have begun to show, yes, we do expect continued low false positive rates in cases of NIPT for all pregnant women. The future, what does it look like? I mentioned that average risk studies are starting to come out. Some clinicians are offering NIPT for all pregnant women. I would venture a guess that the majority are still using it just in high risk at this time, but we do expect that one of the major directions in the future is going to be expansion into the general pregnant population. But additionally, we don't want this technology to have to stop at common aneuploidy testing. It has the ability to do a lot more than that. You heard from various speakers tonight about carrier testing for single gene disorders. We want to be able to help those women as well. Perhaps they're not able to afford PGD, or it's not an option in their particular country. NIPT should have the ability to test to the level of single gene conditions, but perhaps a little more timely will be subchromosome conditions. So Dr. Yu mentioned microdeletion testing. There are conditions that can lead to severe birth defects and mental retardation in babies involving a piece of a chromosome that's extra or missing in the case of microdeletions. And you've seen already perhaps that one or two laboratories offering NIPT recently came out with microdeletion panels. The one publication in the literature thus far was from Illumina, showing that yes, NIPT can detect subchromosome changes, whether they're microdeletions or microduplications. And with that, as of this week, the Verified test now does also offer a microdeletion panel. So thinking back to that genome-wide approach, very easy to quickly add on new test menu content once we feel that it's been validated sufficiently and that it's clinically relevant and being asked for by physicians and patients. So this panel does include the 5 most common microdeletion syndromes. It is similar to sex chromosome aneuploidy testing in that it's an opt-in option. It's not routinely part of the test, but rather it's based on patient and physician decision. One of the main decision points, as you might imagine, would be ultrasound findings. So if we think about 22q deletion syndrome, if a heart defect is identified on ultrasound, that would likely be a reasonable indication to offer a microdeletion testing panel. It's not necessarily something that needs to be available for all women undergoing NIPT, but there are certain cases where it would be warranted. One unique point to mention here is that because that sequencing data does exist once the original Verified test is run, we've made it an option for microdeletion testing to simply be an add-on within 2 months or so of the original test reporting. So patients who have a negative result initially continue on in their pregnancy and have an anatomy scan where perhaps an anomaly is identified, you can simply contact the laboratory and have them reanalyze that sequencing data and report an amended test result with interpretation on these 5 microdeletions. And I'm going to end with that, just showing that the test technology has evolved very quickly and is continuing to evolve. You've seen from just 2012 to 2014 a significant increase in the conditions that we can test for non-invasively, and I don't think that that's going to stop there. So this is just the beginning of what's possible for you and your patients. Thank you. Any questions?
I just want to wrap up the reproductive genetics session of this symposium. The overall idea is to be able to understand what are the needs of the conception care spectrum, starting from preconception, where the couples can already plan for pregnancy despite being carriers. They now have an opportunity to make informed choices by doing carrier screening. Either they could go for IVF, or they could just go ahead and do a NIPT for single gene disorders when that becomes available. Alternatively, they could adopt, they could have a donor egg. So all these possibilities never existed before. It's only now that despite being a carrier, the couples can have a normal child. Going forward, the pre-implantation genetic diagnosis, you already heard several technologies are already coming into the market. Just going beyond the microarray, the sequencing is becoming available for elective single embryo transfers. That's one of the most exciting frontiers of PGD technologies, where you take one single cell on day 3 or day 5, depending on what your habit is in terms of freezing the embryos or not, or fresh cycle transfers. Depending on that, if you start looking at the cost of sequencing, just to give you an example, Dagan Wells at the ESHRE meeting last year just announced that the cost of doing one single cell sequencing from each embryo is just about $70 in the conditions that have been mentioned. So going forward, the cost is likely to come down, and the technology speed is likely to increase. And the newborn screening, right now we are restricted to inborn errors of metabolism. This is likely to expand to other areas like genetic causes of deafness, non-syndromic causes of hearing loss, and many other conditions. So we just want to tell you that as Asia Genomics, we are composed of at least 5 physicians on board right now, and we are looking at recruiting some more genetic counselors. Our plan is to provide you with prenatal, pre-test counseling, test and post-test genetic counseling as well for all the tests that we offer, be it carrier screening or be it inherited cancer screen, which is what is the next topic that